Welcome to HIV Matters Coronavirus and HIV Virtual Town Hall, a program of APLA Health and our Hive program, HIV in Older Adults program. I'm Brian Risley, your host and moderator. Mark McGrath will be taking your questions in the chat box. We're fortunate to have several world-class infectious disease experts with us today. Eric Daar, MD, Chief of HIV Medicine at Harbor-UCLA Medical Center. We have Jerome Vente, Medical Director at APLA Health and Wellness, and Jay Gladstein, MD, Medical Director of APLA Health's Olympic Clinic. Last evening, Mayor Garcetti issued a safer at home order for all Angelenos, commencing at midnight last night through April 19th. Governor Newsom followed this with a mandatory stay at home for 40 million Californians. As of this morning, on the LA County Department of Public Health website, there were 235 known and confirmed cases of COVID-19 and 2 deaths in Los Angeles. Our healthcare system has been described as mired in situational uncertainty. To better understand this novel coronavirus and address your questions, especially of people living with HIV or at greater risk of becoming infected with this coronavirus, we're going to go to Dr. Eric Daar.
Great, thanks, Brian. Thanks very much for including me with this group to talk on this extremely important topic. And I'm going to really just give some introductory remarks to sort of set the stage for others as well as for the questions and answers, which I think will be the most important part. There's still a lot we don't know. Obviously, things are moving. To say things are moving quickly is such an understatement. So let me start by saying that there was a great presentation put together for the virtual CROI meeting last week. Seems like months ago, but it was last week, that included some terrific speakers on this topic. And the first one, oh, I lost this slide.
You'll be here.
Okay.
Sorry.
The first one, the first couple of slides I was going to present was some of the data from the China experience. Obviously, this is where it started. They have the most experience, and they've actually published a lot of their data. And there was a presentation on this virtual CROI by essentially the Chinese CDC head, who talked a little bit about the background as to how things evolved. And he described sort of the very, very beginning of the first described unusual case that came up, and then how within several days, let me see if I still can't see the bottom of the slide, but there we go, thank you. So within several days on the 31st, they announced an epidemiologic alert just 4 days later. So again, it happened very quickly. And then they linked it with this seafood market, just because that's where a lot of the new cases were coming from. They closed the seafood market. And then that was December 31st. The link was made on the 1st where they closed the market. And then within several days, the WHO and other countries were informed, and the virus was identified on January 7th. And I just want to take a minute to sort of provide people the semantics that we all are getting used to. Originally, it was referred to as a novel coronavirus because coronaviruses are obviously a very common virus to cause colds and respiratory infections. This was different. It was ultimately named the virus as SARS-CoV-2, and that was the virus that causes the disease COVID-19. So I think more and more people are referring to the coronavirus, but we're really talking about SARS-CoV-2 or COVID-19, which is the disease. So this, you can see how things progress quickly in China, and the first PCR test became available shortly a day after they sequenced the virus on January 11th. So amazing progress. Added to a notifiable disease by the end of January, and by January 23rd, sort of the unprecedented events that I think all of us were sitting back thinking could never happen here, we're starting to close down cities, and they ultimately closed down areas, regions with as many as 60 million people. Next slide. Sorry. The next slide, now there was a slide before this, I think, but if we can't bring it up, I can speak to it. Oh, bouncing around a little bit. Just one before this. No. There we go. So this is some of the data from the China experience. Obviously, we're quickly getting experience from other countries, including here. But what this describes are the sort of the spectrum of disease, mild, severe, and critical, and that fever was by far and away. And I think most of the other studies have demonstrated the same thing, that while fever isn't present in 100%, it's far and away the most common of the symptoms. And this is followed by things like cough, and then non-specific symptoms. So increasingly, you'll hear people talk about fever, cough, shortness of breath, either or both, as being sort of the telltale signs, very much like a common influenza-like illness. Next slide. What was described, back one, back two. One more. So what was described here, and I think continues to hold based on, well, we'll get there. What continues to hold is sort of a general idea as to the spectrum of the disease. And I think everybody has heard this, that about 80% of people will have a mild illness. So much like what we experience during influenza season, the majority of people will have a relatively mild illness that just requires supportive care at home. And that's going to apply here. But there are a subset, about 20%, that will be sick enough to be admitted to the hospital, about 5% that are considered to be critically ill. And what the data suggests is that the risk factors that appear to be common amongst those who become severe and or critically ill are people who are over 60 or 65, depending on what you read, and people with underlying comorbid conditions like diabetes, cardiac, renal, liver disease, or people who are immunosuppressed. So those are the main risk groups. And the next slide provides a little bit more context for the age-related risk factors, and that you can see that the overall risk of mortality on the right-hand side, and looking at that gold line or orange line, in people who are young, such as 50 and below, the risk of mortality is very, very low. It starts to go up a little in people in their 50s and continues to go up. So it's a continuum. So to say that people who are over 60 or over 65 are at higher risk for severe disease and bad outcomes is true, but it's relative. And it's really when you start talking about people over 70 and particularly over 80, where the mortality becomes extremely high. And as many of you are aware, the sort of the best estimates are about 2 to 3% fatality rate, which is much higher than seasonal influenza that runs on average about 0.1%. And that's a big part of why people are so concerned about, because of the increased mortality. Now, obviously, there's a lot we don't know, and we'll talk about this. A lot of people aren't getting tested, so it's very difficult in the United States right now to have our head around what the true mortality is. But almost certainly, it's going to be considerably more than seasonal flu. Next slide. I tried to just pull some of the most current epidemiologic data, and there's some references at the bottom. The CDC continues to be one of your best references for information for everybody, both for physicians and for our patients. There's also this Johns Hopkins has a live sort of a real-time website that provides continued updated information. This is from this morning. These are the estimated cases and deaths globally, about 250,000. With 10,000 deaths. In China, where it all started, it's 81,000 with over 3,000 deaths. And as you probably know, they report no new cases of community spread in China in the last 2 days. And then Italy has been one of the areas that most of us are keeping our eye on, because it started a bit after China. Obviously, it's Western Europe, but the number of cases have gone really high, 41,000 with 3,400 deaths. So they actually now report more coronavirus-related deaths in Italy than they do in China. And the numbers continue to go up. And the thing that's most alarming, and when people ask me, what am I most worried about with this problem, and I worry about almost everything, I think it's really the capacity of our healthcare system to provide care for the patients. So in the United States, these are the recent numbers, about 14,000 infections, 205 deaths. But I'll show you in a minute, this information is really limited by the fact that testing has been so slow to roll out in the US. In that as many of you are aware, it was almost impossible to get anyone tested until very recently. And then recently, some of the commercial labs have come out and markedly increased our capacity, but they have a huge backlog. And the turnaround time for some of the commercial labs, which was originally hoped to be 2 to 3 days, is often much longer. So when we think about the pace of increasing cases in the US, we do need to look at that in the context of the fact that we really don't know where we were. We know where we're going increasingly, although not perfect, because we are doing more testing, but we have no idea where we were when we look at the trajectories. California, as of this morning, 1,039 cases. I'm sure there's more, with 20 deaths. And LA County, Brian gave you information that he looked at probably more recently than I did. Mine are just from this morning. And it was the 231, if I remember correctly. Yeah, with 2 deaths. And if you look across all of this, you can sort of see where this 2 to 3% mortality rate, 1 to 3% perhaps mortality rate is coming from. But we'll have a much better handle on that as we start doing more testing. And then I have at the bottom that, you know, in Italy, we've missed the slide, but in Italy, the population is estimated, we're told 60 million. California is 40 million. So when we look at what's going on in Italy, in a very short period of time, 3,400 deaths, and we think about the fact that the majority of those people likely were seen in an intensive care unit, and that our capacity for intensive care units in California is some number like 7,000 or 8,000, and then far fewer than that number of ventilators. You can see why we're really concerned that despite only 1,000 cases reported in California, we know that number is higher if we were doing more testing. And if things continue to escalate on the path that Italy went to, we could have not just a national, but a sort of statewide and local healthcare crisis. The slide that, again, we lost that slide, but what was on the right-hand panel was just sort of give you a sense as to the population adjusted number of tests. And if you remember what it looked like, there was a red box around the United States, which was way down on the list. There you go. So 125 per million people tested as of March 16th in the United States, as opposed to other countries, which have been much more aggressive in getting testing done. We're hopefully going to start catching up soon. Next slide. So what do we do about it? You know, I think this is the most important thing from an individual perspective. We'll all worry about the capacity of our healthcare system, but for our individuals and for our family and our friends, it is important to know that we really do know how it's transmitted. It is transmitted by droplets, which are aerosolized when people cough and sneeze. So if we stay away from people who are ill, that's a huge start, and especially those who are coughing and sneezing. And there's pretty good data for a long time that these droplets will only persist in the air, can only go out to about 6 feet. So if you maintain a distance of 6 feet from everybody else, your likelihood of acquiring this, whether they're sick or not sick, should be very, very low. And thus the justification for social distancing and avoiding crowds, especially right now. And then stay away from as many people as possible is a general rule, which is what we're trying to do with the stay at home or home is safe kind of policies. So that's to avoid the droplets. We also know that it's transmitted from surfaces that are contacted by droplets or the hands of other people who perhaps have infectious secretions on them. And then if we touch those surfaces and get the virus on our hands and we touch our mouth, eyes, or nose, we put ourselves at risk. So how do we deal with it? Avoid touching surfaces if not necessary. Obviously, you can't live in the world without touching some, but we touch far more than we need to. Wipe down surfaces that you plan to be touching, like a workspace with standard cleaning products, and then washing your hands regularly with soap and water for 20 seconds, or a hand sanitizer with at least 60% alcohol. If we all did this and told all of our patients and everybody else to do this, we really would markedly reduce the risk of transmission. And then finally, the last connection between the virus and you is your hands and your face. So if you don't touch your face except right after washing, the risk of you acquiring the virus from the surface of anything and bringing it into your own body should be very, very small. So social distancing, staying away from people who may have droplets that'll aerosolized, And then dealing with the surface issue. And the sure way to do that is to wash your hands frequently and don't touch your face. Next slide. What do we know about COVID-19 and HIV? Well, if you haven't had a chance yet, the AIDS info, the DHHS guidelines for adults and adolescents for treatment just came out with a small summary piece describing a lot of what I think I have summarized on this slide. We don't have a lot of data that suggests people with HIV do any worse or a particularly high-risk group for acquisition or progression of disease with COVID-19. But we do know that people who are viremic and have CD4s of less than 200 are generally at higher risk for a variety of other pulmonary complications. So I think it's not unreasonable to at least be concerned about it. But just HIV alone in a suppressed person with high T cells probably isn't at any higher risk. But they are at risk for the same reasons everybody else is if they're older, greater than 60 or 65, heart, lung, kidney disease, or diabetes. So the usual risk factors apply. What to do with HIV in this era of COVID-19? Well, continue all your medications and make no changes in your antiretrovirals. Be up to date if you can on your influenza and pneumococcal vaccine and have access to adequate supply of medications. So you don't want to run out. We're all being asked to stay home. It's getting harder and harder for us to connect with our providers, perhaps get out to the stores and pharmacies. So make sure you're going to have enough access to carry you for the next few months. That doesn't necessarily mean you have to have it in hand, although if you do, that's great. But at least have negotiated with your provider and or pharmacy that such will be available if you have trouble getting out. Minimize healthcare visits. This may not be intuitive, but if you have a regularly scheduled visit with your provider and there's nothing acute going on, you should not be going out for that. There's absolutely no reason to have that as one of your excuses for leaving the house. Stay in, use the phone to communicate about any problems and reschedule. Obviously, if you need to be seen, that's different. The preventive measures like everybody else that we just went through about how to avoid exposure to droplets and infected surfaces, manage illness like you would otherwise, and stay connected with family, friends, and others, even while you're trying to isolate yourself indoors. And then finally, don't forget, influenza is circulating right now. And if you have documented or suspected influenza-like illness, in the first 48 hours, it's probably very reasonable for, in general, and certainly somebody with HIV, to be started on Tamiflu or oseltamivir. And then the last slide looks at, where are we going with treatment? We'll skip over this in the next one. These will be covered separately. But where are we with treatment? So as you've all heard, the vaccine study, phase 1 trials are just started in the last week, but they're going to take about 12 to 18 months, assuming they work. There are several vaccine candidates in development. From a therapeutics perspective, there are no therapeutics that are approved or have been shown to have efficacy for this particular virus. There's a promising nucleotide inhibitor called remdesivir that's been developed prior, and preclinical and some early clinical data for other coronaviruses that's now in advanced stages of clinical trials. There are multiple of them going on and is available for compassionate use for sick people. Everybody, I suspect, heard about the chloroquine, hydroxychloroquine. This is a drug that's been available for decades for malaria and certain types of arthritis, but and has some data that suggests potential activity against this virus. But despite what you may have heard, it was not approved by the FDA for this purpose, and there is very, very little data. But it is available, and we certainly have a lot of safety data. So it is something that perhaps in sicker patients, people might be trying, but it's not because we know it works. There's a lot of buzz about some suggestion that HIV protease inhibitors, in particular lopinavir-ritonavir, might work. This has been under investigation, but there was a randomized controlled trial in China of 200 people that was published in the New England Journal this week or late last week that showed no efficacy. And then there was talk about maybe darunavir boosted also has some activity, and the makers of darunavir, Janssen, came out with a notice saying there is absolutely no data in vitro, ex vivo, in vivo, or otherwise to suggest that this works. Interferon beta, not widely used. Monoclonal antibodies are in development. And there are going to be a variety of other things that are in development. So I think the important message for people is right now we're on our own. There is no solution or answer other than the good common sense behaviors that we can do with regards to avoiding droplets, avoiding infected surfaces, taking care of ourselves, taking care of our family. I think the idea of staying in as much as possible, avoiding contact with people is the sure way to try to curb the spread of this, with the main goal. I mean, everyone has heard the term flattening the curve, but the simple thing we're trying to do is delay the onset of new cases so that we don't overwhelm our healthcare system, which is our greatest threat. So with that, I will stop and turn this back to Brian.
Thank you very much, Eric. That was excellent. A lot of what you're saying is sounding like the early days of our HIV epidemic in the United States. So there's a lot of questions about what is self-isolation and what is self-quarantine. So to help clear up some of the confusion, Dr. Vente is going to speak on that.
Okay, thank you. I think there are some slides that Dr. Daar created. I think if we can have the slide for self-isolation first. I mean, there's two terms that we commonly hear and use in terms of people who are suspected of having COVID-19 or have been potentially exposed to it: self-isolation and quarantine. Self-isolation is something that's used in people who have a known infection with COVID-19 or are suspected of having infection. Where quarantine is something that's done for people who have been exposed or thought to have been exposed to COVID-19, but do not have symptoms. We'll look at talk about home isolation first. And home isolation, yeah. So as I said, for those with documented or suspected COVID-19, and I think this is, as we have discussed before, this is a big issue locally and throughout the United States, in that some people are known to have infection. They have a test documenting the infection, but probably the great majority of people who actually have an infection are just presumed to have it based on their symptoms. I know that locally, the Los Angeles County Department of Public Health is currently recommending to only test persons where, in the judgment of the healthcare worker, of the medical provider, where the results will make an impact on management or inform public health response. So in other words, if somebody is at home and they have a relatively mild flu-like illness or cold type symptoms, but they really are not sick enough to require going to a hospital, they are currently recommending that those people do not go to a medical clinic to get tested. And we just would presume, based on their clinical presentation, that they have COVID-19, and then we would treat them. Then we would institute home isolation precautions. So once somebody has been diagnosed or presumed to be diagnosed, they should take care of themselves and go back to the home isolation slide. Take care of yourself and call their provider if they feel like their symptoms are getting worse, or call 911 if they're severely ill. I think it's important for all providers to take steps as much as possible to try to maintain telephone communication with persons who are suspected to have COVID-19, and to return calls promptly, so we can manage people telephonically as much as possible without giving them reason to need to go out in public and come to the medical office or go to an emergency room to seek further guidance. So if somebody is in home isolation, what should they do? Well, they should stay home as much as possible, have no visitors or limit visitors to home as much as possible. If you're, if it's possible to have assistance from somebody to bring food to your house, bring medications to your house, or have them delivered, then that's a way to help limit your exposure to other people. If there's other people in your household, then ideally you should stay in a separate room away from others, especially those at higher risk, such as people who are older, people who have chronic medical conditions, as we talked about before. Use a separate bathroom if possible. If not possible, wipe down surfaces in the bathroom frequently after use, before use, and stay at least 6 feet away from others to limit the risk of droplet transmission of the virus. And as Dr. Daar said, minimize handling of surfaces, clean surfaces frequently. Of course, cover your cough or sneeze, wash your hands frequently. And if you must be around others, especially closely around others, then you should wear a face mask. How long does home isolation need to last? Well, you should stay home until at least 7 days from the onset of symptoms and at least 3 days after you have recovered, whichever is longer. So it'd be at least 7 days and possibly longer to wait for at least 3 days after you have recovered. I think that this, may be an area of some controversy. I'd be interested if other people have other opinions. I think that, exactly how long someone with COVID-19 continues to shed virus and be infectious to others is not extremely clear. And I'd be interested to know if other people feel like perhaps extending home isolation precautions for a longer period of time, say up to 14 days, might be a more prudent approach. And if somebody is a healthcare worker, I think you would be, or they're need to be exposed to people who might be at increased risk. I think that would call for more caution. And if somebody's a healthcare worker, they would either need to avoid working for 14 days or at least after they've met these minimum criteria on the slide, wear a mask when they're back in a healthcare setting. I think we can go on to the flip side of this is quarantine, self-quarantine or home quarantine. As I said, this is for people who are not sick and not thought to actively have COVID-19, but have been exposed to somebody who is documented to have COVID-19 or somebody who is thought to have COVID-19. And so that would be household contacts, intimate partners, caregivers, et cetera. We know that the incubation period for COVID-19, that is the length of time it takes between actual exposure to the virus and exhibiting symptoms of the virus, is on average about 5 to 6 days, but it could be as long as 14 days. Therefore, when somebody is advised to be in quarantine, it's generally recommended that would last for 14 days following the last contact that person had with the known case, the person who had COVID-19. Restrictions. If you're in home quarantine, you should stay home, similar to home isolation, limit or have no visitors. Ideally stay in a separate room away from others, especially those at high risk, and use a separate bathroom, wipe down surfaces frequently, stay at least 6 feet away from others, no handling of surfaces, including pets. Avoid leaving the house unless absolutely necessary, and you can leave your room to go to private areas away from others. I think it's also very reasonable you can go outside and go for a walk as long as you're keeping a safe distance away from other people. And then, of course, when somebody's in quarantine, if they develop a fever, cough, or shortness of breath, they should call their medical provider for further guidance.
Okay, thank you, Dr. Vente.
Sure.
Dr. Gladstein is going to talk about testing and testing protocols. I know this is very fluid and it's changing every day. I know you'll give us the latest information.
We'll give you the latest information as of yesterday. So Brian is correct. The recommendations, the guidelines on testing are very fluid, and they were changed just in LA County just yesterday. Part of the reason they are so fluid is that we do have a lack of capacity to do all of the testing that is wanted or needed. And we're really all learning about this and figuring it out how to make all the testing available as we go along. We were unfortunately underprepared for this epidemic in the United States in terms of our testing capacity. And that is part of the reason why now we are in a state of really figuring this out as we go along. So when it comes to testing, there are guidelines for providers, and those guidelines are published and revised frequently by the Department of Public Health. Currently, because of the lack of capacity to really make testing available, we are, as Dr. Vente said, encouraged to only do testing when the test results will make a difference in the clinical management of the patient. Okay, so what does that mean? Because a lot of you may think, well, of course it's going to make a difference in the management of the patient. Of course it's important to know if somebody might have COVID-19. And yes, that is true, but from a standpoint of medical management of severely ill patients, it's really going to make a difference for those more severe and critical patients that are hospitalized. If somebody is critically ill and in a hospital with symptoms of pneumonia or shortness of breath, we absolutely need to know what the cause is. And right now, because of our limited capacity to do testing, we're essentially being requested to reserve our testing just for those situations. We, again, because the capacity just isn't there, we don't have the ability to let everybody know whether they may have virus or not. And as Dr. Daar said earlier, even if we are to do testing, we don't really know what the turnaround time is. It's supposed to be a couple of days, 2 to 3 days. I know at my clinic, we've done, I believe, 7 tests this week. We haven't gotten any results back yet. So, and as Dr. Vente was saying, for people that have suspected COVID-19, we're going to tell them to do the same thing, which is go home for home isolation. So that is the current update on testing. It's not very clear. I wish I could give more clear guidance, but the clearest guidance I have is stay up to date with what the Department of Public Health is recommending. Don't panic, which is hard in a situation like this, and stay in communication with people who may know, with your peers, your colleagues, and we're going to get through this together. With that, that's the clearest guidance I have on testing right now.
Good. Thank you, Dr. Gladstein. We're going to go to questions. We have about, I believe, about 16 minutes for questions. So, Mark, can you field some questions for us, please?
I do. So this is coming from one of our Hive clients in Los Angeles, and I'll let any doctor take this. Would any of the MDs on the panel consider virally suppressed and HIV therapy adherent persons, i.e. undetectable, someone with an underlying chronic medical condition? And how should they properly gauge their risk category if they are controlling their HIV infection.
I think, Eric, you kind of spoke to that before. Maybe you can address that.
Sure. No, it's a really important question. I think in general, people whose viral loads are suppressed, probably regardless of their CD4 count, based on our experience, and certainly if people have CD4s over 200, I think we would at this point not suggest they're a particularly high risk unless they're older, and it kills me to say older is 60 or more, or have diabetes, hypertension, heart disease, lung or kidney disease. So I think just HIV in and of itself is not a significant risk factor. And we also need to sort of keep in mind when we talk about having these risk factors, there's nothing you can do about it other than take all the precautions that we would encourage you to take anyway. Most of the people, you know, when we were talking, Jay was talking about how to deal with the panic or the anxiety. To me, probably the best we can offer people is to tell them that one, most people will be fine. And two, there really are some concrete things you can do to protect yourself. This isn't just like maybe if you avoid getting near a lot of people and you wash your hands and don't touch your face, you almost certainly will not get infected. Not maybe won't, you certainly will not. That said, it's not easy to do, and we all need to work on it. So I think those things are reassuring, and that's certainly what I tell my friends, family, patients, that there really are things that we can do to control this on our own. But worrying a little bit about whether you're 60 or 65 or have diabetes, all of that means is you need to continue to protect yourself and perhaps be more diligent than ever.
Wonderful. So this next question is from Bob in Chicago. And Bob wants to know about the possibility of being infected and reinfected with COVID-19. Reinfections?
I'm not sure that I can
I'm not sure
really
anyone
address
can,
that.
actually.
I can't say that I'm an authority on the data. I think there was a report in China of somebody who was evidently was reinfected, but you know, generally with viral respiratory infections, some immunity protection develops after initially having the infection. I can't say how common that would be to get reinfected.
I would completely agree. I think there are a few cases where they're not sure whether it's reinfection or they just relapsed or they never were completely better and then got worse. But based on our experience with other viruses and most of the data that exists, it would seem highly unlikely that you could truly be infected, completely recover and get reinfected. But we don't know, right? There's just not enough data yet.
Susan has a question, and this concerns homeless populations. And we've just talked about self-isolation and that. And what would, how should homeless people best prepare for this?
I guess we can go ahead and each say our piece on this. That's a very challenging point. And they can only, like the rest of us, do their best to get through this period of social distancing and good hygiene. It's just that there are more challenges for the homeless population. So again, I don't have much more to say than just do their best and make use of whatever resources are available. And I have to give a little bit of personal commentary here. I think this is pointing out some of the costs of the holes in our social safety nets. We do not have universal health care in this country. We do have a lot of holes in our social safety nets. We do have a large homeless population. And in a case like this, it makes it evident that this really hurts our entire population. So I don't know if you gentlemen have others more to say about homeless people protecting themselves.
Yeah, I know that in Los Angeles County, the Department of Public Health is the county is making arrangements to provide temporary shelter, new temporary shelter for homeless persons, and I believe that has already started and it's going to be ramped up pretty rapidly, or that's the plans locally in Los Angeles County. At one of the state parks, they're bringing in lots of RVs. And so I would have to refer to the local public health authorities to see what the current situation is.
Yeah, no, I know there's an effort to use, rec centers. We have lots of vacant buildings right now, hotels, motels. I mean, hopefully they'll be able to mobilize those things. But even when you get people into shelters, it's challenging. But at least in a shelter, you would hope we'd be able to provide some of the resources they need to protect themselves. Masks if people are sick, hopefully some social distancing, given the 6 feet, if not more, and cleansing solutions and tissues and trash containers, things like that. But we have to figure out, we get people off the street. And obviously, however we figure out to deal with it now, we should continue it when this is over.
Right.
I think there is a website. It is coronavirus.lacity.org, and that is the Mayor Garcetti's website essentially. So that'll give you updates on coronavirus and the city's efforts to outreach to people who are homeless and other city efforts. It's a daily briefing and the website is updated daily. So coronavirus.lacity.org.
Can I make one more comment? For people who do have homes, I just want to make a comment that came to my mind particularly around home isolation. 80% of cases of COVID-19, based on the Chinese experience, 80% of cases of transmission occur in the home. So we're all told to not spend much time out on the street and to practice social distancing. But if we're concerned that we may have something ourselves, be very diligent within your own home about keeping isolation and protecting those in the home, because they're the ones that are at highest risk of getting it.
This is from Susan in Washington State. She has asthma, and she's wondering how asthma might fall into a risk factor.
Well, I think that asthma is a chronic pulmonary disease, and of course there is quite a gradient of asthma. People who have very mild intermittent symptoms to people who have persistent severe symptoms, and I think that certainly somebody who is more on the severe or chronic spectrum of the asthma illness, I would consider to be at increased risk for severe disease from COVID-19. And so that person would want to take every precaution possible to limit their risk of exposure.
Wonderful. And for everybody here in LA, Katia, who is the APLA public affairs person, just sent me a list that LASA here in Los Angeles is making resources available for persons who are not sheltered. Wonderful. Now, a lot of our patients who have survived with HIV have pets as close family members. Greg wants to know if he should be concerned about the safety of his animal, or I think there was a Chinese report on a dog that got coronavirus. Would anybody like to comment?
I'm not aware of any real threat to our pets from this novel coronavirus. I think the concern that people have raised, and it's hard to know how big of a real concern it is that it's possible that infectious fluids from our hands or from coughing and sneezing could get on our pet and then end up on somebody else's hands as we pet our pets. So thinking of them more like a fomite, a way to spread things than actually getting them infected or them infecting us.
Yeah, I read that report from, I think it was Hong Kong actually. And the speculation was that that something that we sneeze out or cough up got on the dog's fur, and the same way the virus can live on a surface, it can easily live on a dog's fur. But the animals themselves do not seem to be at risk of infection.
The next question is from Greg in Los Angeles, and he was at the CDC's website and they recommended Tamiflu for influenza, but he's having difficulty getting a script from his doctor. should people with HIV have a supply of Tamiflu, or do you think what's your advice?
You know, the CDC guidelines, I believe, have and continue to say that people who are at higher risk for influenza when presenting with within certainly the first 48 hours with an influenza-like illness should receive empiric treatment if you can't test them. And most often our people who are healthy in the community, we don't routinely test because by the time we get the test back, they're nearly completed their course. So it's just, I think in general, and I worry a little bit that we're forgetting about that. We still have influenza circulating in the community, and we're so focused on this. I think the general practices that we apply year in and year out for influenza are still important.
There's no shortage of Tamiflu as we know it, is there?
Not that I'm aware.
I'm not aware of it.
Right.
Good.
But I want to just echo Dr. Daar's point that the seasonal flu vaccine is something we recommend really for the entire population, and that's should be given every year. And the reason that that is so important this year is that the symptoms of influenza are almost identical to the symptoms of COVID-19. And if we can do something to dramatically, significantly decrease the number of people showing up with cough and fever, particularly at a time like this, that's extremely important. So important to get our flu vaccines every year. In terms of this gentleman who wasn't able to get the Tamiflu, Tamiflu is only really helpful if it's given within the first 48 hours of the onset of symptoms of flu. So if your pharmacy told you they don't have it for 3 days, then it's not going to be helpful.
Next question is from Janine in Salt Lake, and she's confused about how people could be shedding virus but not having symptoms, and she'd like somebody to explain that.
Anyone?
Any takers?
Yeah.
Yeah, I mean, you know, it's sort of been the big question. In general, we tend to think of people with viral respiratory tract infections as being infectious when they're symptomatic. And that's sort of comforting for us when we tell people to just stay away from sick people. But there were early reports from China, and I think they've been largely substantiated in other settings, that there probably are some not just people who you can detect virus prior to their symptomatic phase, but probably even some transmission events, although it's always really hard to prove it because you're relying on people's report of whether they're sick or not, because you don't have to be that sick. But I think that everyone believes there probably is a certain level of asymptomatic shedding. I don't think we know how often it occurs. We don't know what proportion of these people shortly thereafter go on to become symptomatic, or how much they're contributing to the epidemic by transmitting while they're asymptomatic. So lots of unknowns. I think the best way to deal with it is to sort of refocus on the things we can control. And that is whether they're symptomatic or they're not symptomatic. If we maintain our distance from them and avoid contact with them and scrub down our surfaces and our hands before we touch our face, we should be okay no matter what.
And then could each of you just give a brief, John wants to know about stigma. You're all infectious disease doctors. You've all worked through pandemics. Can you speak on the negative effects of stigma in this outbreak?
I think there we have some lessons from the early days of the HIV epidemic, very much the same. I see the same kind of stigma. I mean, certainly calling this China virus is not helpful.
I think our patients on the line who have survived HIV are really familiar with stigma, and I think that this is a good opportunity for long-term survivors to become community ambassadors. You've gone through this, you've been through the battlefield, and you know what other people are going to be going through. And I think it's really great if you could share your experience with the community around you. Well said.
Thank you. We have about 1 or 2 more minutes. Any other questions that are online?
No other questions online. I think maybe we could just get final comments.
Sure. Eric, just sort of a summary?
Yeah, I mean, I think, I think we've all repeated enough what's really important here and what we all need to do. And I do think we need to take this public health issue really seriously. You hear a lot of people out there talking about, well, I'm at low risk, so I'm not going to worry that much about it. But I think we also know everybody who's at low risk could become very sick and are at risk for transmitting to people around them who are at high risk. And to do what we're doing as far as closing down the city, to closing restaurants, bars, and gyms, telling everybody to stay home across the entire state, and I'm sure this is going to spread to states across the country. We're doing it because it's the right thing to do, not because of what's best for an individual, but for society. So this is a problem that's much bigger than any one person, and we need to do everything we can to do the right thing and follow what is being advised.
And then Brian, I'm sorry, just one more question. This seems kind of important. Could you let the community know about the APLA food pantry, and that service will continue, correct?
Sure. So questions for about APLA Health's Necessities of Life program. Our 8 or 9 food pantries around LA County will remain open. The hours are the normal hours. If you have any questions, you can call our switchboard at APLA 213-201-1600. But they're going to give you the same information as me. So we're keep maintaining our same schedule for all our food banks, and we have staff, and we have food, and we have the facilities. So that's one essential service that will remain open, and as well as our clinics. Dr. Gladstein can speak to the Olympic Clinic, and
We are open.
you are open. And
And here at Baldwin Hills Clinic, we are open, and we're committed to help people who need immediate medical assistance as much as possible, to return calls, and to allow people to maintain their regular medications. If somebody's on PrEP medications or on HIV medications, we certainly don't want anybody to run out of those medications during this crisis, and so we're committed to making sure that refills are done for everybody who needs them to last until they can make it back into the clinic in person.
And our Long Beach clinic remains open.
Yes. Yeah, the Long Beach clinic is open as well.
And just know, for APLA food pantries, all you need is a diagnosis letter, correct, Brian, to be eligible?
Yeah, they'll give you if you're new, they can enroll you on site. So I think we're going to wrap it up there unless you have any last closing thoughts. I think everything was very well said. We could go longer. We will do another webinar for everybody as this virus and our response to it changes. Everybody stay safe. Thank you for tuning in. So on behalf of APLA Health, thank you to Dr. Daar, Dr. Vente, Dr. Gladstein. Thank you, Mark. And we wish everybody safety and wellness. Thank you.
Be well.
Peace out. Thank you.
Thanks, bye.
Thank you.